there's quite a lot of to talk about in that talk. I've only got 7 minutes in the talk, and I've got less now. But it's so I'll be talking about BC mycin, of course. I'll be mentioning the SUBDUE-1 trial. So I presented this work at the EAU conference in Milan this year. This is a first-in-world study where sub-urothelial Durvalumab has been injected around the bladder to look at with a dose escalation model, looking at feasibility, toxicity, tolerability, and also early signals of immunologic efficacy in patients with bladder cancer. This study was designed as a sort of it's almost a phase 0 study with patients who are scheduled for cystectomy in any case. And those volunteers agreed to have Durvalumab instilled into the bladder with 21 mil injections of drug around the bladder on a dose escalation schedule up to a maximum dose of 150 milligrams. And it was a fascinating study to complete. And certainly we're very grateful to all the participants who took part in that study. And we didn't see any we didn't see any immune-related side effects from that dose being delivered suburothelially around the bladder, which was fantastic. And we did also see clear evidence of an immune-modulating effect, particularly with an increase in macrophage populations. And out of those groups, it seemed to be the M2 macrophage populations which increased the most. That was seen predominantly in mixed and basal tumors as opposed to luminal tumors. So it really was a fascinating study, and it may be that suburothelial administration of PD-1s or PD-L1s or indeed other agents is an entire sort of approach that hasn't yet really been explored or adopted. And there are more studies ongoing in that area that are planned, including we actually proposed to run a study with labeled Durvalumab. So you can actually label the antibody itself, the PD-L1, with zirconium. And we plan to do an interesting dose distribution study where we give the drug in the same way around the bladder, and then using PET imaging, we'll see whether the local distribution in the bladder, whether the drug bound to the zirconium label actually gets out to lymph nodes or gets out systemically, which no one knows. So that'll be fascinating. There's plenty of other studies we'll be mentioning. There's the ZiPUP trial. This is again involving zirconium. This is a zirconium labeled Girentuximab PET scan using the molecule TLX250, which is a molecule owned by the company Telix. And that's studies really looking to see whether zirconium Girentuximab PET, so sorry, I should mention Girentuximab's a carbonic anhydrase 9 binder. And so a lot of hypoxic tumors express carbonic anhydrase 9. And this is the Girentuximab is known to bind to those. It's been shown to be very effective in renal cell cancer. People may be familiar with the Zircon study, which was presented at ASCO. And there's potential appeal in using it for urothelial cancer. It is expressed on urothelial cancer. We don't know how well it will work yet because we're still recruiting to the study. But also because zirconium Girentuximab is metabolized hepatically, there's no urinary excretion. Which is fantastic if you're imaging the urinary tract, and it may be that we pick some upper tract TCCs, or it's particularly good for ureteric TCC. Also, maybe picking metastases close to the bladder that might be missed otherwise. And though it's of course an aspirational goal, because it's an antibody that we can label for PET imaging, that we may even be able to use that therapeutically as a theranostic agent with other therapeutic radioisotopes such as lutetium in the future, for example. So that's an exciting space, and we're about halfway through recruiting that study. I'll also be talking about the ANZUP cystectomy database. This is called ACCEPT, now ACCEPT-U, the U being the inclusion of upper tract urothelial cancer as well. So this is a collaborative exercise amongst interested oncologic surgeons around Australia, where we're trying to collect prospectively a high-quality cystectomy data set in order to report and drive improvement in outcomes, and possibly with enough momentum and enough sites recruiting, we'll also be able to organize randomized controlled trials in cystectomy, which is something which is almost impossible without a truly multi-center approach. I'd also like to mention a supportive care trial, which we're running in collaboration with ANZUP in patients with penile cancer, trying to find out areas of unmet need for men with penile cancer. This is all trials in penile cancer are challenging due to being the rarest of the urologic cancers. And so we're actively seeking patients who would be willing to be involved in that study. And then, of course, I've already mentioned BCG mitomycin, but I'll also be mentioning all of the translational work that's ongoing from that. So we're trying to look for biomarkers that might be indicators of patients who are more likely to respond to combination treatment. And we've had some interesting initial work, which will be being presented at this meeting related to translational markers, which may be impactful. We're also collaborating with San Francisco-based biotech to look at AI to see whether AI techniques can be trained to pick the poor players just based on high-quality digital images of the H&E slides of bladder cancer specimens, and that work's ongoing. And furthermore, we've got other translational work planned in the future where we may be looking at highly novel immune active agents, probably too early to say which ones, but that might be excellent used in combination with BCG and indeed in combination with BCG mitomycin. So we might have a study in the future which is comparing BCG mitomycin, which is obviously immunochemotherapy with BCG, to sort of dual immunochemotherapy with BCG plus another immune active agent. So that will also, that's potentially in the pipeline.